I'm Jeff Cummings, professor of brain science and director of the Chambers-Grundy Center for Transformative Neuroscience at the University of Nevada, Las Vegas. Early diagnosis is so important for the patient with Alzheimer's disease. Our treatment goals are to keep the patient functioning at the highest level for the longest period of time. And of course, the highest level is best if the patient is very early or minimally symptomatic in terms of their Alzheimer's disease course. Now, the patient can take advantage of early diagnosis by doing more advanced planning, making their wishes known when the patient has the least cognitive impairment. These are so important in terms of making decisions in those final pre-dementia phases of life. And of course, from a clinician's point of view, the earlier we make the diagnosis, the earlier we can intervene with therapy. So that in the United States, for example, we have the approval of aducanumab, a monoclonal antibody, which can be used in patients with mild cognitive impairment due to Alzheimer's disease. It is the only drug approved for use in MCI. With further progression, we have the choice of using other agents, but slowing disease progression by early intervention is our major goal. The use of drugs is very central to the treatment of patients with Alzheimer's disease, not to the exclusion of non-pharmacologic therapies, but as a mainstay of treatment. In the United States, for example, we have the approval of aducanumab, a monoclonal antibody that can be given to patients with mild cognitive impairment as long as we know that the mild cognitive impairment is due to Alzheimer's disease, which we establish with CSF studies or amyloid imaging. Of course, as the patient progresses into mild and moderate Alzheimer's disease, then the cholinesterase inhibitors can be used, such as donepezil or galantamine or rivastigmine. And if the patient progresses into moderate or severe Alzheimer's disease, then memantine becomes an appropriate agent in conjunction with the cholinesterase inhibitors. The goals of disease-modifying therapy and early intervention with an agent like aducanumab is to slow the progression of the disease. The goals of treatment with cholinesterase inhibitors or memantine is to improve cognition or to improve function, at least temporarily in the course of the illness. As clinicians, you know that the most important thing is to take a great history. So what has happened to the patient? What has the caregiver observed? What can they not do now that they could do before? What is the origin and nature of the patient's concern or the caregiver's concern? These are the questions that will shape your approach to that patient. Of course, the next step is the neurological examination. Are there focal signs that might be more consistent with vascular dementia? Are there extrapyramidal signs that might be more consistent with Parkinson's disease dementia or dementia with Lewy body? These are very critical observations. Of course, you're going to review the past medical history. You're going to review the drugs that the patients are taking. If the patient has the phenotype of Alzheimer's disease, which is a memory-predominant dementia or mild cognitive impairment syndrome, then there are a variety of tools that are available to help with a specific diagnosis. Most widely available, of course, is structural imaging with MRI. And that allows you to see, has the brain atrophied, and specifically, are the hippocampi atrophied, as is characteristic of Alzheimer's disease. It also, of course, allows you to exclude stroke or brain tumor, subdural hematoma, or hydrocephalus that might be masquerading as Alzheimer's disease. Now, with advances in biomarker development, we now have available to us, particularly in research settings, a variety of alternate measures. So we can now measure the amyloid plaque burden with amyloid imaging. We can measure the neurofibrillary tangle burden with neurofibrillary tangle or tau imaging. We also have a variety of measures in both the CSF and now in the plasma. And we can do the entire ATN, that is amyloid, tau, neurodegeneration framework in both the spinal fluid and the plasma. So we can measure the A beta 42 to 40 ratio for amyloid in both fluids. We can measure phospho-tau, p-tau, 181 and 217 and 231 in both CSF and plasma. And we can measure neurofilament light, or NFL, in both CSF and plasma. In CSF, there are a variety of other measures that we can also use to measure the neurodegenerative process. So in the research setting, we're able to make a very precise diagnosis of Alzheimer's disease. Providing care to the Alzheimer's disease patient and to their caregiver is very challenging, particularly in the private practice setting where time is so limited. That's why it's important to use physician extenders or physician's assistants or physician's collaborators, such as nurse practitioners or physician's assistants that can do much of the work that is done in terms of the diagnostic process. Also, the use of multidisciplinary teams can be very useful. What can a social worker do? What can a nurse do in addition to what the doctor does, so that the patient has more input and more opportunities to benefit from the clinical visit? Of course, there's also the difficulty of measuring cognitive decline precisely so that we know that this is cognitive decline and not normal aging, the changes of normal aging. That can be done either in the clinic by the clinician using tests, or it can be done by a neuropsychologist that has more extensive batteries of tests and normed examples that contrast the patient's condition with normal aging. Of course, there's also some degree of reluctance to be diagnosed by the patient, and there's a stigma associated with Alzheimer's disease. So these are the things that must be dealt with in terms of the one-to-one collaboration with the patient and the caregiver to understand what their goals are for diagnosis, what their needs are, and how can we as a team meet those needs.
I'm Jennifer Bute, and I used to be a GP, and I used to be involved in medical education in teaching doctors and medical students. And I now, since early retirement, specialize in dementia. Well, Alzheimer's dementia is just one diagnosis within the broader category of dementia. It's the most common, but there are many others: vascular dementia, Lewy body, frontotemporal, and many have mixed dementia these days, and the symptoms can overlap, though some might be more typical than others. But they all have similar needs and things that need to be done. But there are also other conditions that can cause the same symptoms. I'm sure you know all those, like depression and stress, anxiety, anemia, diet, vitamin deficiency, thyroid problems. So one has to be aware of all the other things as well. But for all of us, it's to do with reduced attention span, ability to do, understand, or communicate. We get agitated, and we have hallucinations too. We don't recognize people and we get lost. I still remember getting lost on the way to my surgery. It was terrifying. Nobody would believe me, would they? But it always affects memory, but it is not true that all memories are lost forever. Well, there are many professionals that are involved in the early diagnosis, and not necessarily all with the same patient. People tend to have either neurologists or psychiatrists, and then geriatricians with the older people, but there are many people with early onset dementia, because we know that those with genetically transmitted Alzheimer's disease, it tends to get at a younger age in each subsequent generation. The neuropsychologists can test for the different types of memory loss, whether it's episodic, about life events, procedural, about how to do things, semantic, which is the factual, but marvelously, the emotional doesn't tend to be affected. That's because it's in the amygdala, isn't it? Nurse practitioners, community psychiatric nurses and support workers, all necessary. Occupational therapists can adapt the environment. Physiotherapists can promote mobility. Speech and language therapists help with communication problems and also with swallowing difficulties. Audiologists, so important, because if you can't hear, that certainly makes your dementia worse. Nutritionists are important because there's a lot of unscientific diets out there, and people can feel very guilty because they're told if it doesn't succeed, it's their fault. I see a lot of that. Social workers can deal with the planning, needs assessments, and resources. Where also dementia-friendly community coordinators can help, because everyone needs information, particularly at the beginning, about the benefits, tax allowances, transport, and so on. But there's also spiritual support. There are professionals there as well, and they all need to communicate with each other so the person feels confident. And of course, the families also need to be involved, because if they're not, they also can upset the apple cart. And usually in the UK, it's the GP who's the hub for all these people, because if there isn't communication and if there isn't someone in charge, the person with dementia can get so confused and upset, not knowing who to believe and who to follow. So the coordination together is the most important, I think, having so many professionals. Early diagnosis is so important because one has more time to plan ahead, but it can be very scary. So people need to know from the beginning that there is hope and that there's someone who can walk the path with them. They need to understand that they can have some control. They can slow the progression. They need to find out the legal implications, power of attorney, living wills, and they need guidance where to look for help, because so many at the beginning just don't know where to look. They need somebody that they can talk to about driving, end-of-life issues, but not necessarily right at the beginning, but while they're able still to make sensible decisions about it. And then, of course, starting treatment early, because it can and does make a difference to some. Usually one can tell within 3 months. But even if there's no medication that helps, all people with dementia need to be reassured that there's a lot that can still be done, because they always need hope and they so often feel abandoned. We know, don't we, with cancer, even if there's no cure for the cancer, they can feel that someone's walking the path with them and they can do well. So we must do the same for dementia. And of course, there's always rehabilitation. And that is something that people with dementia need to understand. Because when I received my diagnosis, I had no support and no information. So I started writing leaflets, using my medical skills to help others. And I had purpose. And I realized that others also needed to have purpose. It might just be encouraging the skills they still have, perhaps still baking cakes or repairing bikes, but everyone can still do something. And that is so important. There are many non-pharmacological interventions that can make a tremendous difference. We all know the risk factors that can make dementia worse. I sum it up by saying you need to get on your sledge with musical accompaniment, SLEDGE. The S and the E stands for social engagement, because we must stay socially engaged, because that is what fires off a lot of the neurons in our brain. So within the context of social engagement, we need the L, which is laughter. And I have found in my work over many years now with people with dementia, if we can get people with dementia to really laugh, it really makes a difference to their ability to do things, to remember, to talk, even when they've reached the stage when perhaps they're not talking so well. So that is important. D, of course, stands for diet, and that is important. We need to have a good diet. And the G stands for cognitive stimulation, which is not the same as brain training. It is more than that. And I've seen tremendous difference here in my village with the cognitive stimulation, which involves all the other laughter and social things as well. I met Professor Kawashima at a conference, and he talked about what made a tremendous difference in their setup in Japan. And I understood it was just the 3 R's, the reading, writing, and arithmetic. Well, that's how our brains were wired up when we were children, forming new neuronal connections. And there's so much neuroplasticity in the brain. So if we use all those in the same period of time, that can make a tremendous difference to slowing down the progression of dementia. And I know that because I've been using it here for the last 10 years. And then I have 3 principles that cover dementia. And if only the professionals could teach these principles to the people who care for anyone with dementia, so they feel that they have the tools to cope. The first is there's always a reason for everything that they do or say, that feelings remain when facts are forgotten, and that patterns continue. And everything, I think, can be fitted into those 3 principles. I'll just tell you one story to give you an example. When I first came here, I was called down as a doctor, really, to the lounge because the staff who didn't understand about dementia in those days, they do now, said, "Oh, Dr. Bute, someone's kicking off in the lounge." How rude. So I went down to the lounge, and there was a lady sitting amongst the others in the tea room, flaying her arms around and shouting and obviously terrified. So the staff said she won't take any notice. And they were standing over, waving their fingers at her. So I walked into the mist, told them all to go away. And I knelt down on the floor in front of this lady who I knew nothing about, never met her before, didn't even know her name. Well, she was a bit surprised because I was kneeling on the floor. So she was looking down at me rather than looking up at everyone else. And I smiled at her. Well, she was amazed because everyone else was glaring at her. So I smiled at her. So she smiled and I said, "Oh, you've got a lovely smile." So she was amazed because everyone else was so cross with her. So she smiled even more. So knowing that she was now on my side, I took her hand because touch is so important. Of course, COVID hasn't helped that, has it? I took her hand and I said, "Oh, thank you. You've made my day." Well, she had stopped performing, hadn't she? I said, "You have really made my day. I'm so grateful to you. It's lovely to have met you." And she sat there like the queen for the rest of the afternoon. And the staff said to me afterwards, "What did you say to her to shut her up?" I said, "I didn't. I made her feel that she was valuable, that she had contributed." I think primary care physicians need to understand that the patient living with dementia lives within a community of their family and people around, and they have to be involved. So they need to understand and be reassured that the real person remains until the end. And I really believe that. I think many professionals understand or have experienced these periods of lucidity that happen just before someone dies. Well, doesn't that mean they were there all the time? So we need to find the person. And I think that the professionals need to encourage the carers and the people looking after the families that the person is still there and they can still be found. They need to be enabled rather than disabled, because often they're disabled by despair of lack of hope. There is a way to enable speech. It's one of my specialties. I believe anyone even with advanced dementia can still speak. And if carers understand, or even people with dementia, that they're possible to still talk and be found, that gives them hope as well. And I know that I have learnt so much in my 11 years here in this dementia inclusive village. I'm so grateful for it. And I'm still learning. My father had dementia and I looked after him to the best of my ability, but I didn't know all those years ago that I didn't know. And I wish that someone had been around to tell me some of these things. We do our best, but sometimes it's just because we don't know. So let us go on learning until the day we die.